Yes, you're gonna have people turn their backs, but it's time for us to keep it real. Just keep talking that real, bro. Do what you do. I know what you do, so keep doing that. Talk the real.
The HBI lads will see you now. See you now. See you now.
I don't want to cause no problems. I just want to live my life, but I keep on hearing about nonsense.
And we are back. HBI podcast, health, business, and in between. Plus Poppy today, who's yelling in the background, who you can't see. Yes, child, I can hear you there. My name is Dr. Nathan Bridger. I am a chiropractor and strength and conditioning coach out of North Fremantle in Western Australia. And I am joined by the double duo plus the midget in the background. But first, starting on my screen anyway, on the bottom, sitting in front of a row of large gold coins, who he feigns to be an expert all about, the physiotherapist extraordinaire, Mr. Ben Humphries. How are we?
Well, I'm going good. Feeling refreshed. I'm on holidays at the moment, so no complaints from my end.
All right. Even if there were complaints, we wouldn't be listening to them. Yeah, that's right. And the snigger in the top left corner, the sneaky little man himself, the My Body extraordinaire, Myotherapist Menagaris. How are we?
Yes, really good, boys. How you going?
Yeah, very good, mate. Very, very good.
Good.
Yes, yet again, Poppy is joining us for another episode. She is, by the time she can properly talk, she's going to be just killing this podcast game. That's right. Oh, good.
Yes, Poppy.
So,
hello.
It's important, and it's kind of relevant that we can just see her from here up, because today we are talking about the neck, or as the episode is going to be titled, Get Some Neck. Ben, do you want to lay it out for everybody what we're going through today?
All right, we'll do. I think this one is definitely more for the practitioners or the practitioners in training, because it's more aimed at more of the I guess the technical side, but it also will be suitable to clients who want to listen in, and anyone else who wants to learn more about the neck. So what we decided to do on this podcast is to be a bit more organized, and we're going to go through an interview each month. We're going to go through a body part, a joint, some sort of injury as another topic, and then we're going to go through some business stuff, and lastly we're going to go through some contextual rant that one of the boys want to go over, or there's some specific topic other than what we mentioned, and that's what we decided to do. So today we're going to go through more of the I know to some it's more boring, but for us it's more relevant to what we do in our practice each and every day. So we've got a rough layout with how we want to run this, and we're going to go through how you would assess some specific anatomy, treatment options, rehab, and we're going to go through the neck from each perspective, from my therapist, from a chiropractor, and from a physio. So this should be pretty valuable to most of you clinicians out there. And I think that what do you want to start with? Do we want to start with just how you would assess, or I reckon we go into probably some subjective questions that are specific for the neck, and basically how we would go through A to Z a neck assessment. So I might start off by saying, whenever I deal with the neck, there's some certain questions that I like to ask first, and the biggest thing for me is ruling out any serious pathology. So I'll always ask about headaches. I'll ask about migraines, not only if you get them, but the frequency, the intensity, the location. Do you get any associated blurry vision, dizziness, anything like that, or even nausea or nausea? Do you get nauseous? I'll also delve into if there's any trauma involved, if it's a traumatic injury versus atraumatic injury. So we'll be looking at whiplash, concussions, any sort of blunt force or high velocity force to the head or the neck. And that usually will play into if there's anything, that you may need to send off for x-rays, scans, MRIs, etc. Now, other than that, That's sort of the main questions I like to ask first. What about you, Mina?
Yeah, I'm pretty much the same. And for me, understanding previous history of treatment. So, has this sort of thing kind of happened before? Have they seen anybody for it? What types of treatment have they had for it before? Because it kind of gives you an overview of possibly what has worked and what hasn't worked. And that way you get to paint a really good picture alongside all the questions that you ask as well. And a lot of the time we need to kind of obviously follow this up with a lot of range of motion testing. And the biggest thing is understanding as a practitioner whether this is something that's in your scope or out of your scope. So asking these questions is really critical because, for example, for me, I've got, as a myotherapist, I'm kind of really limited to what I can treat. So understanding our boundaries, and this is why we ask these questions, so we know exactly who's the best possible practitioner.
100%. Are you tuning in there, Nath?
Sorry, guys, I'm just making a bottle because somebody won't calm down. But yeah, I think you're bang on there. First and foremost for any clinician, no matter what's going on, is making sure that patient is in the right place, right? Making sure, it's that classic Hippocratic oath, first do no harm. So we need to make sure that we haven't got something, more sinister going on. So I think the stuff you talked about in terms of headaches, I think the other ones we need to talk about, obviously dizziness, faintings, vertigos, night pains, sweats, all that sort of stuff that may say that we've got some kind of vascular or cancer or style issue. Because once you can't, for a lot of that stuff, you can only best guess, rule out. You can't, yes, your bottle's coming. This is what patients are like when they're trying to wait for their results. It's our best deductive reasoning and clinical experience that tells us these things. There's still no way in a lot of cases to completely rule out very significant things, but we are helped by the fact that they're so extremely rare, right? And so it's doing the best thing possible to make sure that first and foremost, you're administering treatment is the right thing to do. I think that's a really important thing, as we're talking to clinicians today, to understand that people aren't there to pay for your treatment. They're there to pay for your evaluation, your expertise when they first come in. The role of the therapist is not as a treatment modality on day one. It's as someone who's figuring out that it's the right place to be and the right thing to do first.
Absolutely, that's good. So I think we might talk about maybe some specific things that are quite common that we see. Now, after this, I think we delve into some, specific anatomy, but I think what we see ties in pretty directly into the anatomy and the anatomy that's definitely relevant to what we deal with and what we can help with. Now, from just a side note, from personal experience, for me, if there's anything that I get problems with, it's with my neck. So I've got a long, skinny neck. I'm tall and I'm looking down all day. So I'm currently seeing Matty at Thrive. He's a chiropractic, Matty Caratelli, and he's helping me a lot with my neck, getting those weekly adjustments because I was getting headaches probably twice a week. And ironically, I was treating people for headaches every day, but yet I was the one who had them. So I had to go and seek some treatments. And for me, a chiropractor has been a game changer for me, getting those weekly adjustments to my neck. Now, why would that be? So a common presentation that we see, right, is cervicogenic headaches that are coming for me from a facet or fascinogenic origin. So quite commonly I see these headaches that are originating from the neck. And as I said, which I call in a physio realm, cervicogenic, obviously mean origin from the cervical region. So for me, mine were mainly coming from my facet joints. So the facet joints, for those playing at home, are the joints that permit rotation, lateral flexion, and extension of the neck. Now, for me, in order to diagnose what a fascinogenic headache is, then palpation is very effective, but also active range limitations in those movements, so rotation, lateral flexion, and extension. And they're pretty pinpoint, I find, when I'm working with cervicogenic headaches. So I see a lot of postural overloading, fascinogenic, cervicogenic headaches. Another common pathology that I see in the neck is like discogenic irritation. So for me, and for you guys, the cervical discs are not hugely weight bearing, but can be quite a problem. And this is definitely not as common as the fasciogenic problems that I find,
Yeah,
but it's definitely more of an acute.
Jumping on there, I think like cervical disc is not rare, but not common. Like it should definitely not for a practitioner, unless you've got, associated radiculopathies and things like that, or significant trauma. A cervical disc is quite rare, and it'll tend to be, in my experience, more in people like yourself, Benny, like with the longer neck, or your more sort of mobile or low neck lean females as well, more prone to that C6, 7 disc sort of base of the neck irritation.
Mm-hmm.
But even then, quite a rare presentation.
Yeah, definitely lower down. But yeah, you can have I think we go into the associated radicular referral, the spinal nerve involvement there. But I find they're more associated with like an acute whiplash or some sort of high velocity trauma, or just uncommonly like a discogenic postural or even overloading sort of thing. What else would I see mainly? And I don't see it much, but yeah, it would be that cervical whiplash injuries as well, which does involve the facet joints usually, and probably the disc as well, and stirring up all the bloody the muscles and that sort of thing around the neck. What about you, Mina? What do you commonly see, and how would you suss that out?
For us, we do a lot with muscle, and there's a lot of tension that we kind of see. A lot of on the palpatory for me is a huge thing. So a lot of the time when we diagnose and when we treat, there's a fine line with myotherapist, because technically we're not actually allowed to diagnose, right? However,
silly.
we can. It is quite silly, but that's why it's just how it is. And that's why we have the option to refer out to other practitioners, which is why I have an osteo at hand with me here. But when we have a look at things, we look at things from a postural perspective. We have a look at things from subjective, so what they tell us is going on. And we also look at it from an intense muscular perspective. So for me, most commonly, I see a lot of tension throughout the neck, and depending on the job or the role that what they're doing really kind of determines what they're going through. So a lot of wry neck, a lot of frozen shoulder that kind of leads up to the neck. There's always a lot of asymmetries and imbalances in muscles. People kind of working in certain situations for long periods of time. So a lot of the issues we get is a lot of tightness through the neck muscles. We get a lot of weakness and adaptations to the structure and the posture that they're holding themselves into. And a proper thorough assessment is really, really important to make sure that their range of motion is articulate, making sure that if they're getting headaches, if they're getting referral symptoms, that we check all that quite thoroughly. And generally, when you palpate, you will generally get a really good understanding of what you're feeling for. But anything of nerve pushing through down the arms or any of that sort of thing, we generally would, we wouldn't treat it straight away. We would get a second opinion at the clinic as myos. And then once we get the kind of clearance that it's okay to treat them, we'll treat.
Perfect. What about you, Nath? You're busy there with the baby.
Give me 2 seconds and I'll be right with you.
Easy.
So it's quite difficult for us, but like generally we'll treat it. If there's no really big injury in terms of whiplash or anything like that, then a lot of the time we'll have a lot of occipital muscle tightness. That's something quite common, and we do a lot of dry needling, a lot of manual therapy, and a lot of joint mobilizations to ease off the pressure of the discs. And we find that quite useful, and a lot of clients really benefit from that.
Easy. I think I like treating the neck, and it's definitely a very common thing. But for me, I think chiros are the king. The kings are getting rid of the headaches, and kings are getting obviously that postural, increasing that postural tolerance, as well as obviously working in your rehab. But I think once you've got a structurally sound spine, which it definitely is up with chiros, then I find that fixes a lot of things.
Yeah, well, I mean, listen, everything's going to come back to baseline function, right? And I think it's the combination there, but having good, strong structural integrity underneath is really going to help. So, in practice, neck pain is probably one of the top things I see. I think it's really important that we as much as this is a neck episode, you can't distinguish neck away from thoracic, away from shoulder. I think even jaw comes into this, and all of that is part of what's going on. So if I'm seeing, people complaining, particularly for me, you're going to see one of two main areas. It's going to be upper cervical or lower cervical, right? You don't see, in the absence of, say, whiplash or other some kind of trauma, you're not going to see a lot of mid-cervical, like, specific. You'll see generalized stiffness, but usually you're going to get that, base of the skull type description, or that, across the top of the shoulders. And I think, Ben, you nailed it straight up. Facet mediated irritation is probably one of the top things we see. Secondary is probably looking at irritation of the muscle, the joint capsule, or the ligament itself. And then from there, I think it becomes, those are all great diagnoses, but it's why, right? So we always start with what's causing the pain, but it's why. And a lot of the time it's overload through muscle asymmetry, through poor movement mechanics, work-based ergonomics, all these kind of things. So that's where, it sounds really kind of cliche, but most of the time getting these things improving is easy, right?
Yeah.
But it's making sure that they stay well. That's the real skill, I think, of most clinicians and therapists. And most of that's about what you're getting people to do or look at beyond the table, as I like to call it. Because especially for me, people aren't on the table that long. So there's a lot of time outside there they need to be working on that.
Absolutely. I think we'll chat about the rehab in a second. So I think specifically, Nath, I know what's involved with when I saw Maddie, like the whole initial assessment. I know it was generalized across the whole body, but specifically, what would you do? So someone turns up to you with neck pain. I know there's probably a bit of a methodology to what you would do. So what would you typically run through?
Yeah, absolutely. So obviously after history, excluding all the stuff we've already talked about, I usually am going to start with range of motion. So I'm going to look at active and passive ranges of motion. I do have the human track system, so I can do that under video and have it recorded as well, which is really cool. I also really like the upper body. Anytime I'm seeing anything, above upper body, I'm going to do a bilateral grip strength measurement, because that's going to show me whether we're seeing an overload between one side or the other in terms of power generation. It's also a real nice one what's that?
Sorry to cut you off. So that's your myotomal testing, right? So
I've got a grip dynamometer. So I will get people to do actual full grip strength and look at left. Go on.
Would you do it just as a general assessment, or are you relaying that back to any sort of radicular or neurological problems, or you?
I'm looking for more from a probably overload issue. So if I've got so the beauty of what I've got is it also will rate people based on a scale of gender and age as well. So I'm getting two readings. One, I'm getting, kilograms per square millimeter, whatever it is. So I'm going to say, so on the left, they may be pulling 50. On the right, they're pulling 55. So we've got a 5, kilogram strength difference side to side. In my mind, once I start seeing over a few kilos, I know that the human body, once it gets stronger on one side, it doesn't just naturally correct things out, right? If anything, it just doubles down on the stronger side. So I know straight away we've got a rotary issue coming across the upper body, which is likely to create a shear type force across shoulder. Probably going to see some tennis or medial elbow issues, and we're probably going to see potentially neck or headache based issues from the shear force that's coming across it. Second, I then get to look at their rating. So they're either weak, normal, or strong. And so, if someone's sitting down in the weak range, well, we know besides just a simple matter of balancing things out, we have to add a lot of strength to this body, because that's the other issue. A lot of the time we're going to see tightness of musculature because of it's weak. In my opinion, most cases a tight muscle is a weak muscle because it's having to work harder than it's capable of. So it's just shutting things down. And so that's one of my big ones. Obviously the active passive range of motion. Then of course we need to do some of our orthopedic testing. So, maximal foraminal compressions. So creating that push down through to see if we're getting any impingement across the nerves, distraction testing. Although I think it has almost no clinical validity, I am legally required to do vascular clearing tests. I'm sure everyone's sort of familiar with those. They literally have no bearing whatsoever, but I'm legally required to tick the box, which is the glory of insurance.
Which ones do you use?
Sharp Purser I use. I can't remember its name right now, but you basically put people into that laterally flexed, extended and rotated position and check for nystagmus through, its name, forgetting
Hall
right
and
through there.
Pike
What's
or
that?
something. Hall and
Yeah.
Pike?
Yeah, that's, I think so. It's
I've
one of those
never
ones
done
where you're
it,
like,
but
it
yeah,
matters
I've
less
learned
about
it.
what it's called, just as long as we're doing it. But
More,
those are probably the big ones I see for the neck. I don't see that much other issue. Occasionally I'll do like a deep neck flexor endurance
pressure
test.
cuff sort of,
It's that kind of stuff, but not as commonly. But I find once we've gone through range of motion and all that things before palpation, that's when I'm starting to get. And I will do definitely in most cases an upper limb myotomal testing. So I'll do dermatonal myotomal testing and see if we're seeing any specific regions that aren't functioning well. And then if we do have like your more, not weird stuff, but if you're starting to see dizziness and all this, I'm probably going to do a cranial nerve examination quickly as well. So simple stuff, just ruling any nasties out. And then from a palpation and also movement strategy, if I'm seeing upper cervical issues, I'm probably going to check the TMJ and see how the translation and rotation is going through there. And if needed, evaluate the pterygoids and things like that as well.
Yeah, and this is really good for people to hear and understand, because a lot of the confusion, like a lot of people don't know where to go for what condition they have. So if you do have these sorts of intense symptoms, this is where I would definitely recommend a chiro or an osteo for these sorts of things. If you know it's just tension, headaches, just a little bit of stiffness in the muscle, that's something that a myo can definitely have a look at. And especially when we look at, which we'll get into the rehabilitation side of things, is where definitely the physio comes in, as well as the manual treatment that the physio can apply. So you can kind of rotate this between all three therapists, but when your symptoms are intense, like dizziness, could be vertigo, could be pain tingling down the arm, all these sorts of things, I would definitely recommend a chiro.
absolutely. I think, Nath, you touched on some really good things there.
Yeah.
And I'll make a comment. That's definitely more in depth than what I would go into. So I think we all operate on levels. We all have a spectrum of what we do and how, I guess, in depth we assess each area. Now, I know that obviously was, as Nate said, insurance purposes, but it's also like high velocity manipulations or adjustments, which can potentially cause more damage than, say, just a deep tissue massage on the neck.
Though
I'm going
to jump on the end of that. The research no longer supports that. And so I think that's something that a lot of practitioners need to come back around. Like for years, there was this concern around, grade 5 or, high HLVLA manipulation potentially being a stroke risk. If we look at the sheer gamut of research that's looked at this over this last 10 years, where we look at the study, I'm going to forget his name now, but in Canada, that looked at just the sheer volume, I think it was something like thousands of lifetimes of data, and saw that the rates of these kind of strokes was the same between a GP and a chiropractor, right? Because primarily what people have when they have these issues is headaches and neck pain, and those are the top two groups they were going to for it. And like for most of the case studies I've seen, anybody who's had one of these things is usually sitting in the waiting room waiting to see the practitioner when they have the issue. It was a study that literally came out in the last 3 months that literally under MRI had people put into that full position and then manipulated, and it showed no strain across any of the arteries. So I think we're almost at that point where we can quite safely say that the risk is extremely remote. Like we used to talk about 1 in 10 million. I would say it's probably even more like vast than that. And even then, the research says that it's probably a pre-existing condition that's missed. And, we have to, as practitioners, do our best to always be able to diagnose things, but then we have to double up. And this, without sounding like a cop-out, the only accurate way to know that a bleed is in progress is to send someone for an MRA. So, an angiogram under MRI. And most patients, even if that patient had neck pain and headaches, because it's not, most people think of a stroke as someone who's like lips drooping, they're falling to the ground. That's often
severe.
not how it begins.
No.
If I had every patient come in and I was like, yeah, before we do anything with the neck, we better go send you for this MRA. It's going to cost you about $1,000 to make sure. It's not going to happen, right? So it's balancing patient expectation with best evidence and clinical experience, which by definition is Sackett's triad of evidence-based practice. But I think any practitioner that's still harping on and saying, and I literally had a patient come to me this week whose surgeon and GP had told them if he sees a chiro, they were going to kill him. Like, these kind of things need to be reported, and people should literally have strikes against their license for lying to patients about this kind of stuff.
Yeah, that's like, and that's a really good point. Like, I definitely don't speak about those things with my clients because I know it's not true. But I wasn't exactly sure of like the data that, as you just mentioned. So I think that's really important for everyone to note, that you can almost not relate the two anymore. Chiropractors with vertebral artery dissection. So that's really good that you've covered that. And I think that
I think it's an important thing. Like, as a profession, we needed to look into it, right? Like, anytime there's a potential negative consequence with any treatment that you do, you need to investigate it. Because one, if it is a legitimate risk, you need to look at other options. And I'll be the first to say, if it was a legitimate option, if it was a legit issue, I just wouldn't use it. And I use cervical manipulation less than I did traditionally anyway, because I find I have other options anyway, and some people respond to other options. But two, you also need to find out what subgroups, who are at risk. And if particular subgroups are at particular risk, well, then we need to make adjustments to how we do things again, right? That is, again, just basic evidence-based practice.
Yeah, 100%. We deal with case-by-case clients here, and obviously you got to handle everyone differently. And as you said, I think it's definitely more important for those learning to know these subgroups and the types of people that might present with these, serious sort of problems. But as it stands, like, I've never seen one, and I've practiced for 4.5 years. I don't know if you boys ever seen one. So it's like, it's something that I think is really badly promoted, and it's it's a nasty stigma that exists. I think that it's good that if it's been investigated, so that it's like, all right, it's not true. So anyone who does promote this, and I hear it all the time, man. I get a lot of clients in who I say, all right, you need to go see a chiropractor, and they're like, oh, I know about that. They've had, it's a bad generational stigma. They've heard bad things, this and that. I'm like, look, I see one every week for the exact same problems that you've got, and I'm headache free. I said that my personal experience and now professional experience is very positive, and none of what you say is true. They're just all rumors, bad PR, and
respectfully to us, we've not done a great job of public relations. I know we're getting down a rabbit hole here. So as chiropractors, we have to wear some of that stigma. And the other problem is, I think we've talked about this before. You go to 100 chiropractors, you're going to get 100 different types of treatment and things like that. So I think Andrew Locke made a point about this the other day, and I think it's very relevant. And I think it's something we've talked about before. So I'm just going to make sure the child's not getting stuck in the door. No, she's fine. It's less these days about the profession and more about the person, right?
Yeah.
Right. And that's the 90s. And that's why, like, for me, I have even already in here, I have 3 physios, three separate medial myos. There's no real myos over here, but Mina, you're going to have to sort that out. You're going to have to bring Mina's myo school over to Perth. I have multiple people in each section because each of them works slightly differently. Each works with different groups, and each is a better personality fit for different people. And so you've always got an option rather than just being like, I know when people are like, oh, can you recommend a chiro here? And I'm like, listen, I've looked at who's there. I'm going to send you to this osteo or this physio or this myo because frankly, I think they're a better option for you than any of the chiropractors there.
Yeah, absolutely. And that's, that just sort of plays into, building a network, having some people you trust, making sure you know people all around your city or your location, make sure you have options up your sleeve. Not only that, but also making sure you've trained yourself in several different ways where you go, well, if this,
and you got to put the mic in your mouth there, mate.
Can you hear me?
Yeah, he is. You're like talking off like you're eating an ice cream, mate.
I'm just saying, you just need to be, if you're interested, you train yourself in several different ways to handle soft tissue work, rehab work, adjustments, dry needling, cupping, whatever it may be, and you make sure you have a good network up your sleeve. So you've got options. I think I use chiropractors and sports doctors as my safety nets. I'm like, because I can't help here, I'm going to refer off to you boys or you girls so you can help my client. A, that way the client gets treated better, but B, I also don't lose the client based off, a failed sort of attempt.
Yeah.
Awesome. All right. I think, Amina, I think Nate's touched on a lot of the assessment stuff. Is there anything else you want to go
No,
into?
that's main thing. And one thing I was going to add that we do as well is a distraction test and compression test for us, because that is a really big differentiator whether we refer out or whether we can actually treat. So as Myo. So again, that's also why I've got Adrian Hubert, who's an osteo with me. And the beauty of it is there's something I'm not sure about, then he'll come just jump in and inspect it for me just to make sure that, we're doing the right thing. But also I think just touching on that, we hear a lot of other people and we have a responsibility here. Like I get a lot of people, oh, that chiro ripped me off. I've been there 2-3 times a week and it's nothing. So it's our jobs as health practitioners to educate clients on what they need to do and what each practitioner actually does, because this is where we can actually change the game by informing our clients, okay, this person does this person does that, and that's why that didn't kind of work for you. But as practitioners, when they present with this sort of condition, we have to be honest, like, okay, I can or I can't do it. So I think once you do that, it will change the stigma of what clients are led to believe, whether it be about chiropractic, physio, myo, whatever it may be.
Absolutely. I even go down to everyone tells me I'm a great salesman for the chiros. I'm like, they work and you want to get better, and this is how you're going to get better. I actually go down to the description of what they will do in their consult. I'm like, you're going to go through this, get this x-ray done. You're going to go through this process. The treatment sessions will only last 5-10 minutes. So it's nothing like what I do here. So I try, as you said, set the expectation very accurately so that the person knows exactly what
I've actually just created a PDF which explains all the different therapies that are offered, and I've actually created that as a huge email out, and I've got them even printed and laminated in the shop, so people can at least read that while they're waiting for their treatment. So just little things like that, just to kind of keep your clients educated and aware of who to see when.
Perfect. All right. Nice on daddy duties. The baby's upset, so we'll keep moving on.
Yeah, cool.
All right. So, treatment. So I know this is very, very generic, Mina, but let's say we're dealing with the most common things you deal with. What would you do for your treatment?
So if I've ruled out that everything's kind of safe to treat, for me, I like to use a number of modalities. Let's say, for example, I've got upper tightness through traps, really tight suboccipital muscles. For me, I love looking at everything as a whole. So even though, let's say, the upper neck is the issue, I actually treat from probably glutes all the way up to neck, on their back after, treat through SEM, through the neck, through the chest, through the front delt. So that way, when we treat everything releases together. And for me, I understand that no one is treated or fixed in one session, but if I can offer as much possible treatment and treatment methodology in the same session, then they're going to get a better outcome. I don't need them to come 8-9 times in a row. If I can be just more effective in my treatment, so I'll work with heat, I'll work with cupping, I'll work with dry needles, I'll do deep tissue, I'll do joint, not manipulation, but mobilization. And then also we test and retest at the end of the session as well to see exactly, show the client, the different outcomes of what happened before we treated and what's the outcome after we treat. And that way, you're educating the client on what we've actually done. So when they leave the clinic, they haven't just left with the appointment time and how much they paid. They actually have a full understanding of, okay, this is what I had, this is what I got treated for. And I explain to them, this is why I do the cupping then, this is why I do the needling then, this is why I apply the heat before and after. So people can understand your process. And for me, that's what I do.
Absolutely. That's really good. Nath, what about you? You tuning in?
Yeah, absolutely. So
I'd say treatment.
Treatment-wise, for me, I mean, obviously it's going to vary depending on the thing, but usually there's potentially going to be some level, either, like I said, spinal manipulative therapy, mobilization. I use a variety of soft tissue techniques, so from just trigger point to full sort of massage to stretch, like pin and stretch type sort of stuff through there. use assisted mobilization techniques, and then from there I'll often use like your PNF style stretch and stuff like that through the traps. Like we were saying before, I'm usually going to also look at thoracic. I very rarely won't look at the whole body, but just in isolation here. But definitely I think thoracic responds very well to spinal manipulative therapy and release work in through there. I think specific areas I always target is going to be suboccipital, scalene, scap, and the lats as probably my 4 main targets in through there. I think they're our like big primaries that are going to give us the most bang for buck. And then again, if headaches up a thing, I may do pterygoid release or TMJ mobilization as well.
Perfect, bro. Yeah, I think touching on that, as we said, we're just talking about what we would do with a common presentation.
Yeah.
I've done a lot of my training with Mina, so I treat very similarly to what a myotherapist would do. So again, using a range of treatments, deep tissue work, definitely through the traps, mid-back, thoracic, as you boys mentioned, definitely up through the neck, cervical paraspinals, levator scap, upper trap, and your suboccipitals. As Mina mentioned, joint mobilizations, especially for the upper cervical spine if there is some sort of cervicogenic headaches involved. And then, depending on time, because we'll all run off time, some anterior work through the neck, the SCMs, and even sometimes mobilizing from a anterior to posterior on the anterior part of the neck, which I find works quite well. And as well as some dry needling work, which is anywhere from all through your thoracic spine, your upper back, scap stabilizers, and then the suboccipitals. I know Mina does a lot of that, and I even saw yesterday with one of your Instagram stories doing some dry needling through the SCMs and stuff, which was which is good.
Yeah, that's been something quite interesting. I've been training a lot of physios actually. I've been training heaps of physios because we're so focused and we always kind of, that forward head posture consistent. Like I've actually got a treatment plan straight after this. I'm really excited because I haven't had
You beauty, mate.
I can't wait. So
you guys need to hurry up and open places over here, man. I'm lagging. This body needs some love.
I know. Venture number 2. Yeah. When we talk about business stuff. But the other thing for me as well is as myos, we need to prescribe corrective exercise where a remedial therapist is actually not allowed. Right? So these are just some of the different, and I will continue to talk about differentiation of what a therapist can and can't do, because these are the questions. Yeah, these are the questions that we always kind of get in the clinic, right? And it saves people time and money and frustration when they know who can do what. So, half the world still doesn't even know what a myotherapist is. So we'll leave that one for another topic. But I know. So alongside, after I treat all that, then I also, for my initial diagnostic testing, I'll understand if there's an asymmetry or weakness on either side of the rotators or lats or neck, whatever it may be, and also prescribe some corrective exercise and spend like maybe the last 5 to 7 minutes, taking clients through that. And because that's what stops them from having to visit us 7-8 times. So when they focus on strengthening a muscle, one muscle could be tight, doesn't necessarily mean it's weak. So I know you mentioned that, Nath, but sometimes some muscles are too strong. For example, we see this quite commonly with the trap muscle, where the lat's not doing its work enough to kind of depress the shoulder back. So depending on your diagnosis, corrective exercise is a really, really, really important aspect to your treatment. And this is where I rely heavily on Benny. And I know when I was working with Benny earlier, he really taught me a lot about diagnostic testing and strength and conditioning. And I still use his programs till today. And obviously I've added a few things from my end, depending on what the condition is. But this is important why, as health practitioners, we need to liaise with other people who are better than you at certain things to make sure you get the best outcomes for your clients.
Absolutely. What about you, Nath? So you're very good at this sort of thing. So we've finished assessment treatments, very generic rehab, but let's run through.
Yeah. So like everybody who comes through my door gets a rehab plan. It's part of the parcel.
That's very unique, Nath. That's very unique.
I think it should be the standard because, again, as I explained to everyone, what my stuff does, and I apologise if the child's making a ruckus in the background. But what my treatment does is speed things up, and then long term, when we work with people in a more maintenance styles, we just assist to minimise stress on the body. What the rehab does is create the long lasting change, and then further, I always talk about. I'm going to have to turn the background off to explain this. Sorry, team. If you're on the podcast and not on the video, you might want to jump on the video for this. But if you imagine, say, we're going to call a gap. You've got your hand sitting on top and your hand sitting below in front of you. That gap between there is your work capacity. So at the bottom is your body's ability to work, and at the top is where injury starts. When most people get to us, that body is already sitting over the top of their capacity, right? And so my goal with treatment is to get them below capacity so they're feeling good. And then the rehab opens up that work capacity so it's harder for them to be re-injured. So a normal rehab program for me, like again, I very rarely am one area specific. I run along what I call the MASS protocol. So 1 second. I do mobility work, activation work, stability work, and then strength work. So mobility for neck, I may just do some cervical extension over a towel. If it's less neck mobility and it's more thoracic that's needed, I'm going to do some thoracic, maybe foam roller release or a modified child's pose. Activation work, we're going to be more rotator cuff. So Andrew Locke's Big Three or simple, ITYs to the back just for high rep range. I'm then going to go to stability working through this. I'm usually going to look at serratus. I'm going to look at lat, as in single arm work. So single arm pull downs with an eccentric returns or single arm rows. And I often will try and have that like half kneeling position. So you're getting that lat off that opposite pelvis to really create that torque position. Yeah. And then finally, and that would be example of some of the stability work, bottoms up kettlebell press is another big one I use depending on people's abilities. But then finally is the strength work. And strength work is usually going to be then lat based and trap. Child, come down. Lat based, trap based, and then probably, hold on guys, I'm going to have to get.
All right. He's doing a really good job. He's trying to manage a baby and run a podcast at the same time while trying to discuss some technical in-depth rehab.
Lat based, trap based, and then just shoulder, so delt based through there. So I use a lot of high rep shrugs under tempo. I do a lot of specific row work, so pendlay row, bent over single, sort of what we call a shallow row and things like that. Deadlifting, sort of the trap bar.
All right. She's cracked it. Nate's opted out. I think he got most of it out.
So that's just to kind of recap what he does. And this is, I think, what I love about Nate versus other chiros is that they offer that overall review as opposed to just the manipulation. And I think for the people the chiros that just kind of manipulate, this is where, for us, we get it, right? But for clients, they really don't understand, it's just a crack, but what about my muscles that are really tight? So that's the fact that, Nate does offer that, I think is a really, really, really critical thing, because a lot of your muscles, your tendons, they all attach to bones, right? So if your joints are quite tight, the muscles also need some help and some strength and conditioning alongside that. So I think how Nate does that combination is fantastic. I think that's what you do, it's what I do. And that's why I think these modalities work. But I always kind of suggest everything that we are talking about is a overview. It's very, very simple. It's not, it needs to be individually diagnosed. So if you do have any of these issues, please make sure you get diagnosed by a practitioner first before you go out and steal any programs from YouTube or Instagram.
Yeah, that's a good disclaimer. I think we touched on a lot of things. I think Nath did a really good explanation of the capacities, and I like to call them just thresholds. It's just like
boundaries.
So you just need to make sure your passive structures, your spine, your ligaments are all doing their job properly, and then we've got to make sure we're strengthening the active support, so your muscle system or your muscular system around your skeletal system, to make sure that A, you're getting your skeletal system looked after, but B, you're getting your muscular system looked after. So we all know that your muscles create movement and your muscles support your joints. So if we can deload the joints, which are giving you the symptoms, through some active rehab, some specific rehab, then your joints are going to perform better. They're going to be a lot less angry, and your muscles are going to be much happier because they have the capacities and tolerances to deal with the load that you're giving them. All right, I think that we covered a lot of things there, boys, and I think that we need to wrap things up. So again, I'll do the outro. First time doing it. Thanks for tuning in, guys. Now, as Mina said, take that with a grain of salt. It's just a bit of an overview. It's very generic information regarding what we would do from each perspective. If you've got any specific questions on what we talked about or specific pathologies, feel free to reach out to us individually.
Yep.
Other than that, thanks for tuning in.
Thanks, guys.
Thanks, guys. Don't forget, 5-star review. Share it on the gram.
Almost.